Good afternoon, everyone. Welcome back to Turning Point TV. My name is J.R. Lane. I'm a recovery coach for the organization. Today, I am really excited to have a special guest on the show, Charles Gurney, a person who's an expert in the field and particularly working with the older adult community. So let's just get started. How are you today, Charles?
I'm fine, JR.
Thanks for coming.
I'm
You know,
happy to be here.
I'm happy you're here as well. Do you mind explaining to myself and the audience your
Oh, sure.
expertise?
Yeah, I'd be happy to.
Okay.
I work for the Department of Health, the alcohol and drug use programs, and I work for DALE, which is the Department of Disabilities, Aging, and Independent Living. So I actually work for two departments, but I have one job
Okay. What job is that?
and one job title. And my job title is Substance Use and Aging Specialist.
Excellent.
And my job basically is to work on improving substance use services for older adults across the state. So I work with a lot of agencies and programs, basically trying to get them to offer more by particularly by way of substance use services to older adults.
You know,
Because
Charles, one of the things that the reason this show came about was because we saw a need for bringing public awareness to the issues of substance use disorder, to gain empathy from the public, and to also at the same time diminish the stigma that's associated with it.
yes,
I'm a person in recovery myself, and obviously my profession is to work with people who are suffering from this illness. And despite that, in my own ignorance, Charles, I never thought there would be a special niche or a category in our own industry where we needed to have a focus on older adults. Can you enlighten me on that a little bit, please?
sure. The way older adults are helped is a little different than the way other adults are helped, particularly with both actually mental health as well as substance abuse
Hmm.
issues.
Yep.
And there are some guidelines for programs to have what I would call age or geriatric specific or geriatric sensitive programming,
Hmm.
because it's a little different what needs to be done with older people. Typically, the way we go about helping them. So obvious things are a slow pace. You know, like if
Okay.
older adults in a rehab and they've got activities going all morning, afternoon, and evening, that doesn't work too well with an older adult.
Right.
It has to be a little bit slower pace.
Okay.
And
Obviously, we've always been aware of the need for special medical in terms of their physical ailments, right? As we age, I'm in that group too. I'm 52 years old and I'm acutely aware of this. So, in terms of mental health and substance use disorder treatment specifically, can we like kind of narrow it down? So, because not only are you're educating me, but we're educating the public more importantly. And for those people out there who have older adults at home who may have a substance abuse issue, I really would like for them to get
oh,
some really good knowledge.
okay, yes, I can respond to that. So the first thing I would say in response to that the older adults have been very significantly underserved in terms of substance use services. Older
I
adults
would
in
probably
need are
agree with
not identified in need and not referred for help, or even if they are offered help, they're not offered help that is that helpful to them because it's not age sensitive. It doesn't
you.
really have to be age specific as much as it really does need to be age sensitive. And the way even substance use, particularly alcohol, the way alcohol affects older adults, the main problem is usually health effects. It's not social effects like it is with many adults, people losing their job or losing their spouse and,
Sure.
lots of social consequences for
Mhm.
as a result of substance use disorder. With older adults, it's their health. And if
That
they're
makes perfect sense.
if they already have chronic health conditions, which Of course, most older adults have more than one chronic
Right.
medical condition. Those conditions are made worse by drinking at a risk level or misusing drugs. And for older adults, the misuse of drugs is, for the most part, misuse of medication,
Hmm. That
not
makes
not
sense.
not street drugs, but
Right.
medication. And in fact, if you look at the numbers, it's roughly 25% of older adults. When I say older adults, I'm talking about people 65 and older in particular, like
Okay.
and the Medicare group.
Yep.
Okay, for that group in Vermont, 25% drink at a risk level.
Wow.
That's one out of,
25%. Those stats
yes,
are that high?
yes, drink at a risk level. Part of the reason that it's so high is because it takes so little alcohol for an older person to be affected negatively. When you're older, because of changes in the body, you
Hmm.
become more sensitive to alcohol. It just takes less alcohol to be intoxicated.
Right.
It's basically
Right.
the issue. And that's also true with many drugs and medications, that it takes less of those substances for the person to be, using too much. So I'm sure that the vast majority of that 25% that I'm talking about who are drinking at a risk level, probably no more than 5% of them are even aware of it.
So
They don't
what
know.
kind of issues are the families seeing now? Are they seeing perhaps convulsive activity happening? Are they seeing lack of hygiene? What is the family witnessing when they're noticing these things?
Well, family would most likely notice it when it's at the level of an alcohol use disorder, which then we're talking about a much lower percentage. Probably no more than 3, maybe 2% of older adults would be diagnosed with an alcohol use disorder.
Mhm.
So that's a small part of that group that I said use at a risk level.
And how do you differentiate that from alcohol abuse?
If
Or
they meet the criteria for an alcohol use disorder, I mean, an alcohol use disorder.
and what is that criteria? Can you elaborate on what that criteria may be?
Well, that's, that list of, I forget exactly how many, 10 different factors that are typically somebody who's a clinician goes through that list of factors with a person to determine whether they have an alcohol use disorder or a drug disorder. Well,
Okay.
many of the questions in that are asked have to do with social consequences.
Right. Right. So it doesn't
Therefore,
apply to the older adult.
therefore, actually, the criteria that are typically used for other adults don't work that well with older adults. What that means is an older adult may be, for example, diagnosed with a mild alcohol use disorder, when in fact they have a moderate or maybe even severe alcohol use disorder because of the way the criteria are worded.
Right.
But
Right.
what I can say, any older adult that does have an alcohol use disorder and is actively drinking, there's going to be the family's probably going to notice this, because they are going to be generally pretty lethargic. Uh, when older adults drink too much, they tend to nod off, fall asleep,
Hmm.
or even become unconscious, and they tend to fall down more. And all of the things you typically associate with being intoxicated are kind of exaggerated, basically.
Right. They
Older
tend to
adults.
get really ornery when they're
Yeah,
ordinarily
yeah,
not.
they're exaggerated. So
Right.
families would notice that. They probably wouldn't notice that their father or grandfather, whoever that family member is, that they're drinking or using medications at a risk level. It wouldn't be as apparent because say if they already have diabetes, so their diabetes is not very good, it's kind of like out of
Mhm.
control. They wouldn't necessarily think the reason that's so much out of control is because dad's drinking too much. But that may be the reason, in fact.
That may be the reason,
That
but
may be
from
the
from the
reason.
way it sounds, Charles, you're saying that you really need a clinician to make that diagnosis.
Yeah, for the diagnosis, you don't need a clinician to know that somebody could use some help. because they're, if they're using drugs, they're misusing drugs and alcohol, then they could use some help, some support. You know, once they recognize that, and that's also where help comes in. How is an older adult going to know that they're hurting themselves with the
Right.
amount that they're using? Well, somebody's got to help them see that. The ideal person actually to help them see that is their primary care provider, right? Because since most of the effects of the misuse is health effects, primary care is more likely to see that. So primary care can do a lot to screen and identify older adults who are misusing substances, whether it's alcohol or their medications.
And the primary care physicians out there are pretty good at distinguishing the social cues that would happen in younger people to the health degradation that would happen in an older adult.
Yeah, absolutely. So they might not even, because they wouldn't necessarily know how much that older adult drinks, because unfortunately, even though older adults are more sensitive to alcohol, older adults are less likely to be asked about their drinking in by their primary care provider than other adults. It's backwards. If
It seems to be,
if
yeah.
it takes less drink for it to be a problem, then it's more reason to make sure you do that screening, or at least ask the patient, how much do you drink, and ask it in a way that you're likely to get an honest answer too. You need to be you need to be not judgmental about it. I mean, if the person is misusing, it's not because they're a bad person. Even you know this
Yes, yes,
well, and it's
yes.
it's
But
just
the public can always use a reminder, right? The public
well, they
can always
yes,
use a reminder
and
to
with
empathize greater.
older adults, since the consequence of their misuse is so often health effects, that's pretty much all we need to talk about with older adults in terms of motivation for them to make a change.
Right.
They don't have to think of themselves as having a alcohol problem. Never mind not think of themselves as alcoholic or something, but they don't even need to think of it as they have an alcohol problem. They have a health problem that alcohol is making worse.
Right. Right.
And that's how it's more important to see it that way. And it's also easier to see it that way, right? Because it kind of avoids the stigma.
That's right.
But we're just talking about a behavior that is basically making your health conditions worse.
Yeah.
And
And
again,
it's even less likely to diagnose an older adult that has drug problems, right?
yes,
Even
yes.
less likely than the alcohol.
But that's changing. I know, for example, because I just was at a conference where I saw this particular chart that from I'm trying to think of the years, from 2012 to 2019, that stretch of time, the number of people, older adults, entering MAT, medication assisted
Medicare, yeah.
treatment, has increased 600%.
Wow. And for those of
Now,
you out in the audience that don't know, MAT, medical assistant treatment, those are drugs like Suboxone, methadone.
yes, those drugs that make it possible for a person with a opioid use disorder to function normally.
Right.
It kind of can bring them back to a normal state of mind and of function.
Yes.
That's what it does. It's not like another way of getting high, which I think some people mistakenly think that, because
Absolutely.
Suboxone's opioid too, right? But it works differently.
Yeah. And
They
even
just
more.
and
Yeah, there's even
buprenorphine.
more.
Well, that's in Suboxone. Buprenorphine is sort of the basic, medication
Yeah.
that we use for the medication-assisted treatment. Well, for many years in Europe, buprenorphine was used as a primary medication for controlling pain.
That's interesting. I did not know that.
Yeah, I didn't know that until recently myself. Well, so one result of that, they've had less trouble with addiction of opioids,
Yeah.
because if they were treating that pain with OxyContin, uh, the chances of
what
somebody
happened here would have happened there.
it's a different, it affects the person differently.
Absolutely.
But nonetheless, even though it's increased by that amount, we're still not treating anywhere near the number of older adults who could benefit from treatment. I can give you a couple important data points about that.
Okay.
One is, of all of the adults that are treated in the programs across the state that are funded by the alcohol and drug use program, of all of those programs and of all the adults they treat, 2% are 65 and older. That's all. While that age group is more than 20% of our adult population, and they do not have these problems any less frequently.
Right.
What does that mean? It means they're 10 times less likely to get treatment or help.
That's right.
Under in our current system. They're not identified, they're not referred, and we don't have enough age sensitive programming. Now, the recovery centers are kind of automatically, in my mind, much more age sensitive. Why? Because there's some older people around. There's older people who are recovery coaches, and there's older people that that are receiving services, and so they have this peer environment, which is really important. That an older adult that's working on recovery have some peer relationships with people who are going to support their recovery.
Yes.
And the recovery centers provide that. Some of the treatment centers, unfortunately, don't provide that kind of thing. There's hardly any peers around.
Right. Yeah.
The counselors are younger, and the other patients are younger.
So as a consequence, it's even that for an older person, when they're already facing loneliness, their lives
Yes.
can be exponentially more lonely.
Yes, yeah. And social isolation is, for older adults, it has been for a long time, a very significant factor for, it's a determinant of health in the first place. Again, people who are socially isolated tend to have more health problems, and their health problems get worse just as a result of the social isolation. They're more likely to have mental health problems because of the social isolation. And also, social isolation for older adults is the number one factor for suicide. So what I'm getting at is social isolation affects older adults very negatively and in so many ways, with substance, mental health, and suicide risk, and their physical health too.
Yeah.
So,
And I would imagine too, Charles, that a major problem with older adults is mixing alcohol or other illicit substances with their prescription meds.
absolutely, there's some medication that we identify as alcohol interactive. What I mean by that, if you take them at the same time, you drink, you take this medication, it's going to have a much more powerful effect.
Yeah.
And which also means it can have a much more hurtful or harmful effect.
Right.
Well, I'm going to go back to those numbers I mentioned earlier. I said 25% of older adults drink alcohol at a risk level. 22% of older adults who drink at that level take one of these alcohol interactive medications regularly. So those individuals are even more affected because of that combination of the medication with the alcohol. And there's also many older adults that are just plain misusing their medication, and very often unintentionally, just like the person who's drinking too much unintentionally because they've been drinking the same maybe all their life. Right now they're older, and it takes half the amount of booze to get drunk.
Yeah.
But they still drink at that level, which is very harmful to them. The same thing with medication. They can take too much of their opioid pain medication, or combine opioids with tranquilizers, benzodiazepines. And when you do that, particularly opioids and benzodiazepines, if a person's taking both of those at the same time, they're 5 times more likely to have a medical emergency, end up like in the ED, because And that just happens, you know, a lot. And unfortunately, it's not always recognized. When a person shows up in the emergency room, maybe because they fell down, they injured maybe they fractured their hip or something. And so the attention, which it should go to is, taking care of this hip. But meanwhile, the cause of that was the person was intoxicated, so they fell down the stairs or whatever, it is. And so that needs to be recognized and talked about.
Absolutely. Now,
Just-
how does the medical, never mind the rest of this, of our communities, how does the medical community parry that?
How do
How,
they,
how do they counteract the effect that of people either misusing their medication due to cognitive issues, or they're drinking while taking their medication and having, what did you say, overactive or
interact,
interactive
alcohol
effect?
interactive medication just means medication that interact negatively with the alcohol.
Okay, now how is the medical community dealing with that issue?
Well, to deal better with it, they need to do more screening than they do. Alcohol screening and medication screening.
Mm-hmm.
They need to ask more questions about that, like knowing that the person, chances are, if they fell down because they were quite intoxicated, broke their hip, and ended up in the ED, if they do a blood test to check their alcohol level, which many times they would do that, I think, and they could see from that. So that means responding to that. What can they do? They can call a recovery coach.
Absolutely, right? So it sounds like we need to
That's
educate our doctors.
that's exactly how it should happen, so that you can have somebody relate to that person in a way that's going to be helpful to them starting to understand that maybe they're in the fix they're in here or one of the reasons they're in this fix is because of their use.
Yeah,
If they
yeah,
make that connection, then there's some motivation to change. You don't make the connection, there wouldn't be motivation for change.
right, right. Because ignorance is not bliss in this scenario. Yeah,
I think the recovery coaches in the ED is probably the best thing that's happened for older adults in Vermont that would have substance use issues, problems, because it's more likely they're going to get, I mean, the medical people in the ED, they know that recovery coaches are available, right?
yeah, yes, they
So
do.
that means they're going to probably look for, people with these problems more.
One can hope.
Yes. And I mean, hopefully they would particularly do that from my point of view with older adults.
I was talking to a medical assistant treatment doctor yesterday, about a program that we're initiating here in this part of the state. And, one of the things that he said, and he's a medical doctor, he's an MD, is that the stigma in the medical community is oftentimes more severe than that in the general public. Do you find that to be a true statement?
Yes. I think that stigma is still pretty universal in our culture.
Mm-hmm.
Even people who are practicing social work or medicine or psychology, these professions, you'd think that they would be more mindful about those conditions and not
And
accept,
be more empathetic.
and just not stigmatize using the way
Yeah.
it's done. And so again, that's why I talk about with older adults, to avoid the stigma, talk about the health effects as a result of the use.
Mhm.
That's key,
Yeah.
I think.
Okay. Well, then,
Also, many older adults that actually have a substance use disorder, in other words, their use is gotten to that level,
right.
about, well, it's not just about, I know the figure, 37% of them have a concurrent mental health disorder. So many older adults with a substance use disorder also have a mental health disorder. Not all, but well, I said it's about 37%. So that's quite a few.
That is quite a bit.
It's a third. And for probably most adults, the mental health disorder that they're most likely to have is depression.
because of social isolation,
because of social isolation and many other factors.
many other factors.
And
Yeah.
when you are clinically depressed, it's pretty easy to drink too much. Even though
Yes.
the alcohol is actually making your depression worse, you don't, that's not how you experience it. What you
Right.
experience is bad feelings go away because you sort of numb yourself, right?
Exactly.
And so they don't make that connection that this depression that they have is made worse by their use, or not, even though in the moment they think they're helping themselves,
Yep.
but not in the long run, they're not, for sure.
You're absolutely right, Charles. So that leads us to believe that any anti-stigma campaigns that are happening out there right now need to continue full force, right?
Absolutely. We need to get used to really seeing and dealing with substance use disorders as illnesses, chronic illnesses that people need help with, need treatment and help. And for
Yes.
substance use, the help that they often need the most is just support. I mean,
Yeah.
support of their recovery. That's
Yep.
the help. It's not although there are also medications, particularly for alcohol, in addition to, the medication for opioid use disorders, there's
Mhm.
medications for alcohol use disorders that are not used enough. Primary,
Better medications than Antabuse,
yes, oh, absolutely.
like
Like
Vivitrol, for instance, right?
yes, yeah, and
That's a great medication.
naltrexone, which help what that does is reduce the craving.
Mhm.
But that's important because that craving that goes on, in the brain as a result of the disorder is really hard to deal with. So if you got some medicine that can just take the edge off that, and otherwise you want to cut back or quit, it becomes an easier job to do.
That's right. I mean, it's that craving that compels users
Yes.
to use.
And, primary care, any patient that they identify who wants to cut back on their drinking could benefit from naltrexone. Any patient.
Whether they have substance use disorder or not.
Or not. If they want to cut back and it's not easy for them to do it, that this medication could help them do it.
That's good to know.
Especially if they are trying to cut back. It's going to make them help them succeed rather than fail. Now we don't typically prescribe it that way, unfortunately. Not only we don't prescribe it typically that way, sort of generally across primary care, we don't even do that when people go to alcohol treatment programs. They're not, you know, routinely put on medications like opioid use disorder, much more routine.
No, they're not. In fact, that was my primary drug of choice was alcohol. and I
Research
was
has
never off of that.
research has clearly demonstrated that these are effective medications for helping people with alcohol use disorder.
Yeah.
So they should be used very routinely for someone who wants to stop or cut back. Now, you don't prescribe it to someone who has no intention of changing,
Right.
because that isn't going to make that much difference. But if they want to make that change, this is a support. So, between peer support and medication support, a person can get enough support to actually, change their life around.
Succeed,
Because-
even at a late age. Even at a late age.
Actually, I can give you another interesting figure.
Okay.
Those older adults who have a substance use disorder that get into treatment, that actually get into treatment,
Stay sober.
have a higher percentage of treatment completion than other adults.
That doesn't surprise me, Charles, although I gotta say, because of the stigmas that are out there, a lot of people would argue that older people are too set in their ways, they're stubborn, they think they know it all, they don't ask for help, they don't really let themselves get help, etc. Please respond to that, because I gotta tell you, when I was preparing for this interview, Charles, I talked to multiple people, and that's the first thing I heard from almost all of them.
Yeah, that's an attitude that really gets in the way.
Sure
That
does.
it's too late. Some form of that. Or what else does this person have to enjoy? Why would I want to take away his drinking or her drinking or something? this attitude really is a problem. Older adults are just actually many older adults don't even. I'm put it in a different way. Many older adults develop their alcohol use disorder or their uh, drug use disorder in their older age. So it's fairly recent.
So that contradicts the set in your ways argument, huh?
Yes. And those older adults are the most treatable, and it's easier for them to change, to cut back or to quit. Somebody who's a lifelong person with a substance use disorder, it's going to be harder for them. Like, in the way that you typically happens with older adults is that they relapse or have a recurrence, of the disorder in their older years.
Mhm.
They may have been in recovery for 20 years, but
Yeah,
now they're 70 years old and they're depressed and live alone, and they got all this time on their hands, and so they're drinking more. Then they have the return of the alcohol use disorder. They're helpable too, but it would take more support for that person because it's a lifelong condition as a as opposed to a recent condition. It does make a difference because I mean the brain hasn't changed as much. You know what I mean? The damage that's done to the brain is done over long years of drinking too much.
yeah, yeah. And you
Somebody,
really, I mean, of all the people that we're working with today, Charles, we don't see a lot of wet brain. We don't see that kind of damage very frequently. We see more immediate damage, car accidents, divorce, separations from their children and loved ones because of their behavior while intoxicated. Those are
yeah,
the immediate results we see very commonly. Things like brain degradation due to substance use over long periods of time isn't something we see very frequently.
but I wasn't thinking so much about the brain degradation that way. I was thinking about the chemical changes that create the craving.
Okay.
That's in the brain.
Yep.
The way it affects some neurotransmitters and the limbic system in the brain. If that's been changed for many, many years so that they're still having cravings,
Yeah.
then if they then relapse, say again, when they're 70 or whatever, it's going to be harder. They may need intensive treatment to get, back into recovery.
Right.
And
Right.
you asked,
It's not impossible.
what can families do? Well, families need to be kind and supportive, but also realistic. If they know that their loved one, their family member, their father, their whatever, mother, whoever it is that they're concerned about, if they in their own mind think that this is partly caused by their use, they should talk to them about the effects. Not so much focusing on the use as I think your drinking, Dad, is really making your diabetes go out of control a lot. It does. You're in the. You have to call the doctor every other thing about this. Well, if you cut back or stop, your diabetes may be better controlled with the medications you're taking.
Mhm.
That's what can be said. Not this. You got to know you're an alcoholic or something. I hate that word now. To tell you the truth.
I hate it too. I hate it
because
too.
because it's automatically a stigma word.
Absolutely.
You can't use that word without it being stigma. Just like addict, terribly stigmatizing word.
Yeah.
We,
Thankfully that we are seeing that. We're seeing language change throughout the recovery movement and mental health movement. And I'm
yes,
so thankful for that.
yes. Um, Older adults also, when they are in recovery, it's really helpful for them to get support in that from all of the different sort of professional services that are involved with them. So it really needs to be a kind of a coordinated effort. Who am I talking? I'm talking about primary care. I'm talking about aging services agencies. Say if the person's connected to the Council on Aging,
Mhm.
all of these helpers in their life need to be on board. They need to
And that would
find
include the local grassroots community organizations as well, right?
absolutely.
Definitely want them on
that
the.
they're
at the
going
table.
to work together to help this person in their recovery.
Yes.
And then it's much more likely to happen than if only one person's work. I mean, what can happen if they're not working together, you may even be in cross purposes. Somebody may be saying to this older adult, "Oh, you should drink whatever you want to drink, at your age." Somebody else is,
I've heard that actually.
yeah, talking to them about they really need to cut back because of their medical conditions. We need to be on the same page. We have to
Right.
find a way to work more together and with family too. We want the family to be supportive,
And
not
encourage.
critical, but supportive. Stay in
That's it.
that role of recognizing that your father, whoever that, we're talking about, or your mother, whatever, that they have a chronic illness. This isn't bad behavior. I mean, it looks like that, probably, right?
Mhm.
But that's not what it is. It's an illness, a chronic illness. The family needs to understand that too,
Mhm.
in order for them to know how to respond. I mean, if you have a family member who has a recurrence of cancer, you know,
You
which
don't harp on them about that.
happens a lot, does the family get angry at the person that they have had a recurrence of
No,
cancer?
they get concerned.
They get concerned and they want to help them. Well, this is
Yeah.
the same thing. It's
Thank
just
you
a
for saying
different disorder. That's all.
that. That's all. And there is hope for this disorder. There's treatments out there available. And as you pointed out, Charles, many community members also, but we do need to get on the same page. Anecdotally, what would you advise a greater community, Charles, on this subject?
Well, I think that people need to talk about it among themselves more. I mean, particularly the the helpers that are already involved with an older adult, because most older adults have some helpers in their life.
Mhm.
They certainly and mostly have a primary care provider somewhere. And, those people need to be not only talking to the person they're helping or their patient, whatever, they need to be talking to other providers of services to that same person. I mean, for example, they have a case manager at the Council on Aging. That person ought to be on board too. So you're working together. Not that you have to communicate a lot, but you have to communicate enough so that you're all choosing to be supportive in this person's trying to make a change. That's
Thank you. That was
that's the
wonderful.
level that's necessary. Well, that means working together too. I mean, that does mean you talking to physicians or you talking to aging services providers and them talking to you
Yeah.
with the person's permission, obviously. I mean, again, we're talking about a disorder here, a medical disorder. So you got to do this with the person. I mean, basically, but I'm sure you see it this way too. An individual really needs to self-manage their recovery. They can get support in doing that, getting coaching to do that, but
Right.
they need to be the decision maker
Yeah, I absolutely agree with that.
from the get-go, and others need to see it that way so that they can be more helpful in supporting that person as opposed to trying to change them against their will or something.
Which 9 times out of 10 would drive them back to their drug of choice.
Yes, no, that does not work.
It's
And we know
counterintuitive
that.
and counterproductive. Yes.
It is. It's support, not punishment.
Thank you, Charles, for taking the time out of your incredibly busy schedule, all the way from across the state.
Yeah,
Fortunately, we're in the same time zone. Right. I've really enjoyed talking to you, and I just want to say thank you so much. What you're doing is incredible work. Please come down to Springfield and visit us. We would love that, and educate us some more. We're always wanting to learn as much as we can to support those who do suffer from this chronic disease that is devastating, not only to the younger population, but as you heard, to the older population as well. And always at the end of the day, let's treat each other with love and kindness. And
yeah,
remember,
absolutely.
and remember, right, that these older adults took care of us for many, many years. And, it's not fair that sometimes we discard them when they become too much to handle.
Right.
That is just not right.
No, it isn't. But let me just give you one word at the end here to
Please do.
think about, which is what anybody who's going to be helpful to somebody else with a alcohol or drug problem of any kind or a mental health problem, they they really need to be compassionate with that person.
Yes,
There's just means the compassion goes a long way.
it certainly does.
That's what enables you to connect and meaningfully connect. And for older adults, that connection is really important because I know that there are some older adults, probably way too many, who feel at this point in their lives that they do not matter to anybody else. And that's a terrible state to be in, to think, I don't really matter to anybody else. Mm. So, but if we treat people with respect, kind, and compassionate, they're going to feel like they do matter. Even to
That you
people
have
that are
value.
not, even people that are not their family or friends, like if their doctor's compassionate, they're going to feel, well, I matter to my doctor because, he treats me in a way very respectfully or whatever. It's any of those. That to me, that's the key position we need to work from a compassionate position towards others that we're going to help.
Words to live by. There you have it. Charles Gurney, everybody. It's been a pleasure, Charles. And thank you all for tuning in to Turning Point TV. And I can't wait to see you the next time. You have a great afternoon and a great weekend because today is Friday here on my calendar. Take care, Charles. Thank you.
Okay, well, thank you.